In today's episode, we are going over a case study of a weightlifter who gets good old cervical radiculopathy. Let's do this. So, what was the subjective examination for this patient with cervical radiculopathy? 1 week prior to coming into physical therapy with me, she had some extreme pain radiating down her arm and some into the neck. And she doesn't really recall a specific event that had led to this. She did remember dropping a barbell on her neck. It was about 2 or 3 days before the onset of pain. So she was doing power snatches and she tried to bail with the barbell behind her and kind of tapped her on the upper back slash neck on the way down. But it's not like she had a whole bunch of pain at the time. Later on, a couple days later, went to sleep, woke back up again, and just had this kind of searing, terrible pain down the arm and a lot of pain and stiffness in the neck as well. Although the arm pain was worse than the neck pain. At the time, she went to the emergency room just because it was so scary, right? And not only did she have a lot of pain going down the arm, as well as pain and stiffness in the neck, she actually got a lot weaker. So she literally couldn't bring her arm overhead. And that was the most alarming thing. So obviously, she headed to the emergency room to figure out what was going on. In the emergency room, they just got some x rays, they ruled out fractures, and then essentially, they didn't even really give her a diagnosis. They just said, you need to see a spine specialist. And because she knew me and she knew of us, she felt comfortable going to physical therapy prior to going to see a specialist. So, a bit more information about this patient. She's a 28-year-old female. She's a strength coach and a massage therapist, and she's a big fan of weight training in general. She does like the Olympic lifts. She's not a pure Olympic weightlifter, right? So sorry if I kind of bait and switch anyone here, but she does do a lot of Olympic lifts. She also enjoys a little bit of functional training. She likes the Ninja Warrior training and parkour type stuff. Very fit, very strong person. And now I've got a free guide for you today. It's an evidence based cheat sheet to cervical radiculopathy. We go over all the fundamental basics for diagnosis and treatment of cervical radiculopathy. It's an 8-page PDF, and I'll take you from a novice to an expert extremely quickly. I'm going to leave a link in the description so you can go ahead and download that right now and get learning. From the best of her memory, she doesn't recall any sort of history of neck pain or arm pain or anything that would resemble prior history of, let's say, disc pathology in the neck. She basically has a clean slate in terms of neck pain. So, what kind of activities aggravate this at the time? So, basically, it hurt all the time. It was one of those things where she really couldn't get much relief, right? There wasn't a position that felt a whole lot better. Generally speaking, with a lot of these case studies, we talk about, let's say, which movements in the gym end up giving you pain and problems. She was just so irritated and painful. She stopped every activity within the gym. She was having a hard time existing on a day-to-day basis, right? So she couldn't really find any positions of relief. It was just kind of continuous and constant in the neck into the arm. What was actually a little bit nice is she had a relatively fast reduction in pain, right? So the first couple days were absolutely horrible, and then the pain started to go down, down, down over the next several days. And what started with a lot of pain and stiffness in the neck and pain down the arm, most of her symptoms were actually more weakness in the longer term. In the short term, most of the pain went away within the first few weeks. She also reported a bunch of numbness and tingling, some kind of paresthesia, abnormal sensations down the arm, which is a bit of a dead giveaway for cervical radiculopathy, or at least some sort of nerve involvement. In terms of her career, we already talked a little bit about this, but she's a massage therapist as well as a strength coach. And given all the weakness that she had in her arm, as well as all the pain, it was really keeping her from being able to do any of this. And a big problem for her at the moment was, when am I going to be able to get back to performing massage? Because as it stands right now, I can barely move my arm around. It's so painful, it's so weak. How the heck do I get back to this stuff, right? And again, I normally talk about folks getting back to strength training, these case studies, but she had to get back to work, right? She had to get back to her life. That was the first big problem and hurdle to overcome. What's really nice is she's a very disciplined person and she loves strengthening and conditioning. And what's really cool about those folks is that they're willing to do just about whatever it takes to get back in the gym to do the things that they love, right? If I give them 10 exercises, they're going to do all 10 and they're going to ask, hey, should I do this twice a given day, right? That makes it really nice for me as a physical therapist because I know I'm not going to be trying to rack my brain coming up with interventions that are easy to accomplish, picking one or two exercises I think are best simply because I know this patient isn't going to do more than that. I know that she's going to be very disciplined and she's going to be eager to do as much as I tell her to do. So that's really nice from a PT perspective. So, how about her training age? Well, she's been training for a long time and she's been training in a variety of different ways. So, a lot of Olympic weightlifting, but like I said, a lot of parkour, a lot of general knowledge about strength training. She does this professionally, obviously. So, she's really, really good from a weight training perspective. And what's really nice for those folks is that when I start developing, let's say, a home exercise program, I can really rely on them to know the best techniques, right? And the movements they're trying to get back to. So it just helps things out a lot. And it's going to influence the way I write program with these folks. In terms of prior healthcare, so did she go and see a specialist prior to seeing me? No, right? And in a lot of ways, this is a bit of a problem, and I'm getting ahead of myself, but I actually did recommend she go see a spine surgeon just because she had so much weakness. So, what are her goals at this point? Well, she's hurting a lot. Okay. She can hardly move her neck. Neck is killing her. She has this crazy radiating pain down her arm, and she has a ton of weakness, right? So, big thing is she wants to get her pain levels to go down, right? But secondarily, and maybe most important, is she needs to get back to work. She has to be able to support herself, right? She uses her hands for a living, and she does this with massage as well as being a strength coach, right? Now, as a strength coach, you can kind of get away with using one arm and maybe having someone else demo for you for a little bit. But in terms of massage, she needs her strength in order to do her job, and a substantial portion of income is coming from that. It was a big goal for her, right? And then lastly, and this is really isn't in her mind at this point, she would love to get back to higher level strength training, Olympic weightlifting, like I said, some of the parkour stuff. But that's going to be secondary to get out of pain and back to work first. So, what was the objective examination for this patient with cervical radiculopathy? Well, for one, we did a lot of strength testing. Okay. So, in folks that may have cervical radiculopathy, it's nice to do some strength testing because that can rule in cervical radiculopathy if there's going to be some sort of weakness side to side, and also gives us a little bit of information about what level is involved, right? So we went through a full upper extremity manual muscle test procedure. What we found was weakness into external rotation. I gave her a grading of a 3 out of 5 on a 0 to 5 scale, and that's a moderate amount of weakness. Shoulder abduction was actually the weakest movement, and that was a severe weakness. She couldn't even move completely through gravity, and I would say that was about a 2 out of 5. And that is considered severe weakness. And just because she's having severe weakness, if people have moderate to severe, I usually send those patients immediately to a spinal surgeon just to get a second opinion and see if the best case moving forward is some sort of additional treatment that I can't provide, right? She had moderate weakness into internal rotation. I graded that at about a 4 out of 5. And again, moderate weakness in a T position. So laying prone on your belly, arm coming up, horizontal abduction into a T position. I gave that a grading as a 3+ out of 5. How about range of motion? So in the neck, she was definitely limited with range of motion. The biggest limitation was extension. So when I asked her to extend on her own, she was about 75% limited. So very limited there. When I asked her to perform rotation side to side, she was also limited. But what's a little interesting here is she was bilaterally symmetrical, right? But about 40% limited on both sides. In some folks with cervical radiculopathy, you'll notice that they're going to be limited towards rotation on the involved side. For her, it was actually both. And the extension checks out as well. So if I extend my neck and I have cervical radiculopathy, that's going to compress the nerve root a little bit more, closes down the intervertebral foramen and creates symptoms, right? And it does make sense that the flexion was not bad, right? I think it was a little bit limited, but not too bad, just because flexing at the neck seems to increase the intervertebral foramen and can reduce symptoms in those folks. In terms of her shoulder range of motion, if I asked her to move her arm fully overhead on her own, she doesn't have the strength to do it. However, if I check her range of motion passively, it's 100% within normal limits, symmetrical, looking good to go. Normally, with my patients, I like to do some sort of regional interdependence, check their squat, check their step down, lunge patterns, all that stuff. I didn't do much of that today just because she had a traumatic injury. So she dropped the barbell on her neck. And is ankle stiffness a relevant cause of that? Maybe. It's just that at this point, I think there's much bigger fish to fry. And then as we start to progress back to Olympic lifts over the course of time, I'm going to start doing more regional interdependent stuff. But this point, I just didn't do it. In terms of movement analysis, the biggest movement that was off, we'll say, is just going to be shoulder abduction. And it's off because she can't even bring her arm fully overhead, right? If I ask her to bring her arm fully overhead on her own, she can get to about, I don't know, let's say 60 or 70 degrees. And if you look at her shoulder blade, she did have a shrug pattern. She also had increased upwards rotation of the scapula. So essentially, she probably had, and we're getting ahead of ourselves a little bit, weakness within the deltoid, and the shoulder is not able to come overhead fully. And because of that, the shoulder blade is trying to help out. So you get the upper trap kicking in, this raises the anterior, and you're going to get upwards rotation of the scapula with elevation, as opposed to pure glenohumeral motion, trying to get that arm overhead. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free Mini Course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. So did this patient have any imaging? No, she came directly from the emergency room. The x-ray was negative. But the x-ray doesn't always give us good information about what's happening from a soft tissue perspective. Now, do keep in mind, when folks have cervical radiculopathy, that could be from a herniated disc. That only occurs about 30% of the time. Oftentimes in cervical radiculopathy, you'll have degenerative changes that causing narrowing of the intervertebral foramen. But also keep in mind, this is a young person. It's in a 28-year-old. And people that have severe degeneration, usually this is later on in life. If I had to guess at this point, I would reckon she had some sort of disc pathology creating this issue right here. But again, we didn't have the MRI imaging in order to figure that out. How about palpation? So initially, this patient was pretty tender in a variety of places. The areas that were most tender were in the scalene, so right on the side of the neck, as well as the upper trapezius and levator scapulae. We actually got more tenderness over the course of time in the upper trapezius and levator scapulae. And again, that was probably just because those muscles are trying to compensate for other weaknesses at the shoulder. But initially, she had a lot of tenderness there, as well as in the side of the neck. Most of her pain was also in the side of the neck and in the shoulder blade and shoulder region, which, thinking about it now, probably does match up with the type of nerve root injury that we think she has. In terms of sensation testing, it was more or less about the same side to side, but if you did touch the side of her shoulder down to the elbow, she did have diminished sensation. It just felt a little different side to side. In terms of special tests that we performed, because what we're trying to do is try to rule in issues at, let's say, the neck over the shoulder, right? And we did a few tests in order to figure that out. So the upper limb neural tension test was positive. She also had a positive distraction test as well as a positive Sperling test. So when we did these tests, it reproduced that numbness, tingling, kind of burning, shooting pain down the arm. In terms of red flag testing, I didn't see any, which is good. At this point, it means we can proceed with physical therapy treatment. The only red flag that we did find with this patient is that she failed to subscribe to the Fitness Pain Free channel as well as like this video. And I want to make sure that you actually like this video, or you may end up with a cervical myelopathy. Not good stuff. We also did some reflex testing with this patient. There was a diminished reflex at the C6 level. This would be the biceps reflex. Now, given the weakness that we found where the patient was feeling her pain, so think about in the neck, in the shoulder blade region, where she was having diminished sensation. So, again, in that same area, weakness of shoulder abduction, right? A little bit of a deficit in terms of biceps flexion strength. I diagnosed her with a cervical radiculopathy at the C5, C6 level. All right, so we came up with this diagnosis. What are the next steps? What is the decision making? Do we need to send back to a doctor? Do we start treatment right away? What are we doing at this point? So, the first thing that I recommended was that she probably goes back and sees a physician. And the reason being is that she has severe weakness, right? She can't even bring her arm fully overhead. Okay. Now, the literature in lumbar spine radiculopathy is pretty clear that if you have a radiculopathy with moderate to severe weakness, then you probably want to undergo some sort of emergency surgery early on within the first, let's say, 48 hours in order to have the best long term outcome from a strength perspective, right? Now, there isn't robust literature to show the same in the cervical spine, right? So just because we don't have the literature doesn't mean it doesn't exist. At least for me, if I see someone that has moderate to severe weakness, I'm sending back to the doctor right away. The only problem is she's already a week out, right? And if she was going to get some sort of emergency surgery, she would have done it right after the injury, which brings us to this point of people probably need to be triaged a little bit better in the emergency room. So if the emergency room docs know that when folks have severe weakness, especially in the lumbar spine, but also in the cervical spine, they probably need a spinal ortho consult right away to determine whether or not they get surgery. Because what ends up happening is that we see them a few weeks later. At that point, they're not going to be a good candidate for emergency surgery anymore. And they may end up with longer term issues because we didn't make the right decision from the get go. Spoiler alert, she never ended up going to a surgeon. So to this day, we didn't get an MRI. We're not exactly sure what was going on within the neck, but based on the clinical examination, I think we can be relatively certain of what was going on. The next really important step is to monitor for progressive symptoms. So basically, if the patient comes in week one and they've got a bunch of weakness, okay, and they come in for their second visit a week later and they're actually weaker, that's a bad sign. And that means you have to go to the surgeon immediately, right? What's at least a little bit nice if someone has moderate to severe weakness, if you tell them to go to the doctor right away and they are progressing, by the time they get to the doctor, hopefully they can pick up on this and then they may make a decision to do surgery right away because you're having progressive symptoms. It's obviously a bad thing. And that is a red flag, which may require emergency surgery. Now, with all of that out of the way, we can just start our physical therapy treatment. So now you know how I like to treat my patients with cervical radiculopathy. You still need to know some basics about cervical radiculopathy. What am I talking about? You need to know how to diagnose your patients. You want to know things about, let's say, prevalence, anatomy. What are the best treatments for cervical radiculopathy? Should you be doing exercise, manual therapies? Should your patients consider things like injections or surgeries? When should you recommend things like injections or surgery with your patients? What are medical red flags? All of that good stuff. I have a complete guide. It's a masterclass for cervical radiculopathy. I'm going to leave a link in the corner. Definitely go check that out, and I will see you in that video. And lastly, thank you so much for joining me today with this lesson on cervical radiculopathy. You truly allowed me to do what I love for a living. I love educating. I love learning about this stuff. I love sharing. And I wouldn't be able to do it without folks like yourself. So thank you. If you're watching this on YouTube, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step by step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.